Thank you, Dr. Mendelsohn. Thank you to all of the organizers for the invitation. I will say, after Dr. Marshall this morning talked about the early colon cancer rates that we're all seeing, I looked up that article in the New York Post. It says that oat milk is responsible for possibly increasing the rates of early colon cancer, which is surprising and makes me feel better that I had Grader's ice cream last night because I had regular dairy milk. Okay. Well, thank you very much for that introduction. And I did recently move from Mount Sinai, where I've been for 15 years, to the Yale Cancer Center. I am, oops, let's see. Okay, these are my disclosures. You heard about some of them during the intro. So prostate cancer is a disease that's still interestingly defined by the actual treatments that we give, these so-called clinical disease states. And you can see from these graphs that you start on one side where you start with clinically localized prostate cancer and you remove it or you radiate it and you cure those patients. They never go along this spectrum. But prostate cancer remains the second leading cause of cancer death in the United States. And that's because not all of these patients, not all of these men are cured with surgery or radiation. And they go through this series of disease states, from a rising PSA or biochemical recurrence to hormone-sensitive disease to ultimately castration-resistant disease. And the treatment landscape, since I started in this field over 25 years ago, has really changed quite a bit. And in fact, I'm not going to talk about all this. We don't really have the time to, but everyone knows that there are these new androgen receptor pathway inhibitors, or ARPIs. In pink, you can see that there's chemotherapy has been around for a while, docetaxel, cabazitaxel. Sipuleucel-T, which I also won't be discussing, our one approved immunotherapy, and radium-223. But we do have new treatments, including PARP inhibitors, which, again, there's not new data on this. We can certainly talk about in the Q&A the role of PARP inhibitors. It helps about 20 to 25% of patients with prostate cancer. And I will be focusing on this really exciting new therapy, LU177 PSMA, the first, I'd say, clearly effective radioligand therapy. I think it started in neuroendocrine tumors, but has really changed the landscape in prostate cancer. So what is LU177 PSMA? Well, this is how it works. Prostate cancers express a cell surface marker called PSMA. It's not PSA, it's also a protein, prostate-specific membrane antigen. And the idea behind this is that you tie a therapeutic radioligand, in this case LU177, which is a beta particle, and it basically delivers a lethal dose of radiation to the cancer cell directly. And of course, this is not from this year's ASCO, but this was a study called VISION, which was published in the New England Journal now a couple of years ago, that demonstrated a survival benefit. And just for the sake of reminding you what VISION did, this was a randomized trial of patients with CRPC, or castration-resistant prostate cancer, who actually had to express at least one PSMA-positive lesion. PSMA imaging, or PET imaging, has really transformed GU cancers. I mean, it's amazing. In 1 year, I haven't ordered a bone scan in several years now, and in 1 year, it's changed how we actually manage these patients from localized disease to recurrent disease to CRPC. It has really transformed the field. And in this case, in the case of CRPC, it really is telling us who's a good candidate for a treatment like LU177 PSMA. And in fact, the majority of CRPCs express this. And this is the randomization. These were patients who had already received an ARPI and chemotherapy. So this is really third-line therapy. And they were randomized to receive standard of care, which in this case usually was another ARPI. So maybe they got Abi and they switched over to Enza. They were allowed to continue something like that. They just weren't allowed to get chemo, because this is also myelosuppressive. So if you're getting chemo, getting a radioactive therapy, a radioligand therapy, would be potentially too bone marrow toxic. And they were randomized 2-to-1 to receive LU177 versus standard of care. And you can see that this is the RPFS dramatically better with the group that received LU177, a hazard ratio of 0.40, over twice as effective in terms of PFS. And then OS was also significantly better, and you can see here a hazard ratio of 0.62. So this has already become a standard of care based on the VISION study, and we are using this in our clinic every day. Just to show you some other secondary response rates, like you can see here, the PR rate is significantly better really quite dramatic. And these are, remember, late-stage patients who had already received AR-targeted therapies as well as chemotherapy. And if you use PSA, which we still do, and we can discuss how important PSA as a marker is, but we have not gotten away from PSA as a marker, you can see that the response rate, a decline in PSA of 50% or greater, is much greater in the group that received LU-177. So this is clearly a dramatic and very effective treatment. It does have side effects, and they're listed here and just with the arrows. If you look at grade 3 to 5, you can see there's some more fatigue, some bone marrow suppression, dry mouth because the parotid glands actually express PSMA, so you'll see that a lot of these patients will have a dry mouth. Some patients will have a kind of a delayed renal toxicity, although you can see the rate is still pretty low. So this is a new standard of care, and it has been for the last year and a half in patients who are post-chemotherapy, post-ARPI therapy. So what did we learn recently? Well, first of all, I wanted to show you what these look like. This is an example of an exceptional responder, and what you can see here is on the SPECT images as well as the PSMA PET, this is in this case gallium, with a patient who has a PSA of 880. They have multiple bone and liver mets, and when they receive this treatment, even the next day, this is actually, what's interesting is you can image them right after they get the treatment because it's also seen on a PET scan, on a SPECT scan, and you can see that they light up, which is showing you that you're targeting the cancer. And after 1 month and then 3 months, you can see the PSA goes down dramatically, and these lesions clearly improve. But there are poor candidates for treatments such as this, and this just shows several examples. On the left, you see somebody who has, these are paired PET scans. Now, we're not doing paired PET scans, but the Australians who really kind of set the modern standard for how to evaluate candidates for PSMA-directed therapies showed that if you do an FDG and a PSMA PET at the same time, you'll find patients who actually are poor candidates for a treatment such as this. And in the first case, you can see that the patient has a relatively, they do have a PSMA positive scan, but in panel B, you can see that they actually have also FDG avid disease, but low PSMA avidity despite the amount of cancer that they have. And then you see on the two right panels, you see discordance. You see more FDG uptake either in the bone or in the soft tissues that don't show up on the PSMA PET scan. So this is happening, I'd say, somewhere between 5 and 10% of patients. It may actually progress over time, especially after treatment. So it is something that we should be aware of, although we're not doing routine PSMA and FDG PETs, not least of which because insurance doesn't always cover it. But if you suspect a patient may actually have more disease than is seen on a PSMA PET, I do often try to get an FDG PET in those patients. So there are a couple of trials that have come out because one of the questions that patients are asking us is, do we actually have to give chemo? I have given chemo to my patients just so they're eligible for LU-177. So I have a patient, his wife and he are both in wheelchairs. He has Parkinson's disease. And I could not give him LU-177. The insurance continued to refuse it. So I gave him docetaxel in low doses, and he actually responded, and he tolerated it okay. It's the key to being a good oncologist, of course, is to know how to adjust the doses. And we've been around 15, 20 years giving docetaxel. So he ultimately did, in fact, get the LU-177. But the question is, does it work better in the pre-chemo space? And this is one of the first studies that looked at pre-docetaxel, and again, very similar randomization. And you can see the rPFS is quite dramatically in favor of PSMA 617, LU-177 PSMA versus an ARPI change. So this is a very controversial control arm. ARPI change means you just go from Abi to Enza or Enza to Abi. And you remember, there is a treatment here that could be a better control arm. It's chemotherapy. These patients haven't received chemotherapy. So people have criticized this in the prostate cancer world. But in fact, be that as it may, the PFS was quite significantly in favor of the LU-177 arm. And you can see it's rPFS of 12 months versus 6 months. So almost double median. But survival is actually no different. And there's a lot of interesting questions about this. Probably the main reason is shown here. Over 57% of the patients actually crossed over in the ARPI change group. That's in the group that was assigned an ARPI as an alternative. And in all the patients, it was almost 80% had the LU177 anyway. So prostate cancer is becoming like breast cancer in that it's harder and harder to see the OS endpoint because patients are getting all the therapies. On the other hand, we might have expected that these very sick patients might have actually had a benefit from starting a drug like LU177 earlier, and we didn't see it. And there was a second study at ESMO, which I'll show you in a minute, that also shows a similar outcome, which, the question is there something different about these patients after chemotherapy that would make them a better candidate to get this drug after chemo versus before? But at ASCO this year, there was an evaluation of the patients by trying to predict who might benefit, and this was a ctDNA analysis from the PSMA-4 study, so here's that study. And what we saw was, regardless of the treatment you were in, the percentage of ctDNA in your blood was associated with an inverse relationship to your rPFS. That is, the more circulating DNA you have in your blood, the worse you do. By itself, not very interesting. Doesn't really predict who's going to benefit. The other thing they looked at was the presence or absence of these molecular alterations, including AR amplification and P53 alterations. And again, not a surprise, these are poor prognostic features. So there's nothing in some of these, sometimes at ASCO, we go to ASCO and we're disappointed because we see something that gets a podium presentation, but it doesn't really change what we would do. We can do these blood tests, these circulating DNA tests, but it wouldn't really make, and it hasn't changed my practice about who would be a candidate for this because it's not clearly enough to really drive who should get one of these treatments. Oops, okay. At ESMO this year, there was a second study called SPLASH. So this is an alternative to the LU177 PSMA 617 that I mentioned earlier. It's called PNT 2002. It's actually a very similar drug, but it's slightly modified. You can see it on the bottom. But it uses a very similar approach in terms of its targeting. And it was a very similar design. You can see this is a pre-chemo study with an alternative LU177 compound and randomized 2-to-1 to receive this versus an RP switch. And actually what you see is very similar to what I showed you earlier with PSMA-4. Well, actually it's a little bit less impressive, right? You can see that the PFS curves are different, statistically significant, but not as impressively different, and no difference in OS. Probably for a similar reason, a very, very high crossover rate. I think it was about 2/3 crossed over. What was interesting, though, is they used a relatively low dose. And, I'm not a nuclear medicine or radiation oncologist, physician, so I don't, the dosing of this, we rely on our colleagues who are trained for this. But they used a relatively low dose, and you can actually see what's interesting. It's always worth looking at the side effect profiles. And if you look at the serious treatment emergent adverse effects, you can actually see that it's less in the treatment arm than it was actually in the placebo arm. So that's always a good sign that it was very well tolerated. And you do ask the question over time, because these secondary endpoints like health-related quality of life and time to opiate use were actually better. Some of these patients, I've noticed over the years as I've treated these older men with prostate cancer, that they're pretty frail. And sometimes if you give them the full dose of what was done in the randomized clinical trial, they really don't like it or tolerate it in ways that maybe a treatment population in a randomized trial might. And just to show you, this was also from ESMO, not ASCO, but what people are starting to do, this is from the Australians, are starting to move PSMA up front. So the upfront PSMA study. This was a phase 2 design. And what they did was they took metastatic hormone-sensitive patients, so not castration-resistant like the prior 2 studies, but up front at the time of diagnosis of MHSPC, and they gave them 2 cycles of PSMA 617. And then they followed it with the standard of docetaxel, which is 6 cycles of docetaxel standard along with ADT. And their endpoint was PSA response at 48 weeks. So remember, this treatment is done. The 2 cycles are done within 12 weeks. So this is looking at it about almost a year later. And you can see that the response rate was 4-fold better in the group that got the LU177. Now, there are other studies going on in this space, and one of the interesting things is if you give a drug like this that targets PSMA, and then you get rid of the PSMA-positive cells and they're getting ADT, and you're putting the cancer into remission, will giving more than 2 make a difference? So there's another study called PSMA addition. They're giving 6 of these cycles instead of just 2. But will it work if you're actually, if the cancer is going into remission? We had the same conversation with chemo several years ago. Like, does it work if the cancer is already shrinking? And if the target, in this case PSMA, is actually going away? More to come on that. But of course, they did look at and reported PFS, and it's quite premature, I think. But there was a trend towards an improvement in radiographic PFS. But of course, these men do live for years, which is good. So OS, and they get other therapies afterwards, so OS is no different. And this is the PSMA addition study that is giving 6 cycles. We haven't seen the results of this as yet. So just on RLTs, because it's such an important area in prostate cancer, I'd say the imaging has really transformed the field. We can certainly talk about that more for urologists, for oncologists, for radiation oncologists. It's really changed the way we manage this disease. Vision has become the standard of care in the 3rd line after ARPI and after chemo in the setting of CRPC. But we're going to see it shift earlier. I think the FDA may review this data. Whether there's updated survival data sometime in the spring of next year, I'm not sure. They may accept the PFS endpoint. So far, they haven't. And so I think it'll be an interesting question about whether we have to keep giving chemo, even a little whiff of chemo, in order to be able to give this important and effective treatment. And I'm not going to talk about it today, but there are alpha particles. There are other beta particles. This is a very, very hot field, as everyone knows. Prostate cancer is a very good target for this. Neuroendocrine tumors, of course, as well. But the question will be with other diseases, with bladder cancer, with breast cancer, with colon cancer, are we going to start to see radioligand therapy versus antibody-drug conjugates? These are all ways of delivering effective cytotoxic treatments with more smartly than the way we do with chemo. It's targeted, and it clearly works in this particular disease. Okay, I'm going to shift gears in prostate cancer to EMBARK. EMBARK is a study that was already also published in the New England Journal, and it was this design. This is the earlier disease state, the rising PSA after surgery or radiation. I see quite a number of these people. Some of them stay with urologists, but I think the question that we've never understood is, when should you put them on hormonal therapy? Now, these guys do not like hormonal therapy. They do not like being on ADT. And there's actually never been any benefit proven of starting ADT just because your PSA is rising in the absence of a visible disease on a scan. So this study randomized patients to either ADT plus enzalutamide versus ADT alone versus enzalutamide alone. So this concept of enzalutamide alone or ARPI monotherapy, what's interesting about that is that your testosterone doesn't go down. In fact, it goes up. And these men generally do feel better, although I'm going to show you that because this abstract was all about health-related quality of life, I'll show you that, at least with enzalutamide, there's no difference in quality of life, although I will tell you that my patients generally feel better. But this is from the New England Journal paper, and you can see that this is ADT plus enza versus ADT alone. You can see this is PFS, very significantly in favor of the combo. But that's not so interesting, To me, that was not that interesting. If you give 2 androgen-targeted therapies, they do better than if you give 1. What was really surprising is they did a second analysis here of the enza versus ADT alone. And now ADT has been a standard of care for 70 years for prostate cancer, right? 70 years. And in this case, what appeared to be true is enzalutamide alone was more effective than ADT alone, in this case, leuprolide alone. And that was pretty, I think, important because if I was using ADT monotherapy 20 years ago with a drug like bicalutamide, that's a lousy drug. But enzalutamide clearly is more effective, and these patients do better with, if you're going to give one drug, it's better to give a drug like enzalutamide rather than leuprolide alone. And generally speaking, they do feel better. So I'm going to whip through these very quickly. These are the quality of life. All you have to do is notice that they're very similar, okay? I'm not going to spend any time talking about them. All the quality of life instruments in EMBARK were actually overlapping, with this one exception. When they stopped the treatment, you see the treatment suspension is all the way on the left. What you see right away is that, and in this case, improvement is down. The red bar is enzalutamide monotherapy. And these guys feel better pretty quickly. Why? Well, their testosterone's like 500, 1,000. they have plenty of testosterone floating around. When you're on leuprolide alone, your testosterone is 5 or 10. It's very low. So when you stop it, it takes months or longer for your testosterone to recover. But when you stop it on enzalutamide alone, the testosterone just floods into your body and you feel great right away. You feel great right away. And that's what you see here. But after up to week 97, after they stopped it, they all kind of went back to feeling about the same. I don't fully understand why, but that was the main conclusion. So these are my conclusions. Health-related quality of life is comparable, but I would say in real life, my patients seem to prefer ARPI monotherapy. Not all of them. Some men do really well on ADT, but of those who were on ADT before and hated it, they seem to tolerate this a little bit better. It also showed that, we know that EMBARK showed that enzalutamide is plus or minus ADT is better than just ADT alone. So that means it's a new option for these patients with a rising PSA. And after stopping treatment, the hormonal symptoms improve faster if you're on enzalutamide alone. So it is an option. If you're not using it for your patients, I would consider it. But the one thing that I warn patients about is because your testosterone goes up, it gets converted to estrogen in your breast tissue. And these guys all get nipple tenderness, and they also get some breast swelling. So there is data that shows that if you just radiate, give 1 or 3 shots to their breast tissue, that you can ameliorate that slightly. Even if they don't want that radiation, I warn them about it. And it does get better when you stop it. But generally speaking, their muscle functions better, their energy's better. They just generally feel better. They don't get osteoporosis, for example, either. All right, and the last prostate abstract I'm going to talk about is DLL3. So neuroendocrine tumors all over the body express this marker, DLL3. And it's called delta-like protein 3. And you can see here, in this preclinical study, from benign all the way to CRPC tissue, you get increasing expression of DLL3. And why is this important? Well, in May of this year, for small cell lung cancer, because of course small cell lung cancer is the prototypical neuroendocrine cancer, this BiTE molecule, or bispecific T-cell engager, it's kind of like a CAR T infusional therapy. It's just an antibody that pulls a T-cell and the marker, the cell surface marker that you want to bring the T-cell to. And this was approved for lung cancer, small cell lung cancer, and this is the structure of this molecule. And at ASCO this year, they showed an abstract of that same drug in prostate cancer. Now, they didn't just pick DLL3 expressing tumors. They picked all kind of small cell-like or aggressive variant. And they had to have molecular features of that aggressiveness. And you can see that the response rate was actually a little bit disappointing, but there were people who responded. I think the overall response rate here is 10%. But if you actually had a DLL3 expressing tumor, it was actually 20%. So, you know, this is not the same as small cell lung cancer, but we know these patients do very poorly. They develop brain mets, they develop liver mets. These are the triple-negative breast cancers of prostate cancer. These are treatment-induced neuroendocrine cancers. They do very, very poorly. So I haven't used this in my clinic yet. It's obviously not approved, but I think we're going to see more and more about DLL3. Okay. Some people ask, what can you do in the meantime? Platinum is still, just like in small cell lung cancer, it's the standard of care for these patients. The one thing I'll warn you about is just always remember to image their brains. We don't usually image brains in in prostate cancer because it almost never goes to the brain. But now that these men are living longer and longer, actually, it's very important to image their brain. Sometimes you forget because you're not thinking of it, and I have had patients relapse in the brain. Okay. I'm going to, how much time do I have? About 10 minutes? Yeah. All right. I'm going to do some bladder and renal, just some brief updates. It was not a great year for GU abstracts, actually, at ASCO, but these were probably the most important ones. This was an abstract of Checkmate 901. Everyone knows that nivolumab plus GemCis is a standard of care based on Checkmate 901. And they basically, this is the original design, so I don't have to remind you that this is one option for you for patients who present de novo with metastatic urothelial cancer. And what this group did was look at the patients who developed a complete response. Like, what were the characteristics of those who got a complete response? And you can see that if they had lymph node-only disease, you were enriched, and I'm going to show you that in some of these other graphs. So per central review, you can see that all randomized patients had about a 57% total response and about a 21% complete response, but you can see that it was really enriched in the lymph node-only patients. And you know, we see this in a lot of cancers. Lymph node disease seems to behave more favorably, but here you see a really dramatic CR rate relative to the all-comers. And if you look at the location of the lymph nodes, whether it's in the pelvis, retroperitoneum, or distant, you see certainly pelvic and retroperitoneal have a particularly high response rate, high CR rate with Gemcis-Nivo. And when you drill down to these patients, you can see that it's the 12-month CR rate is actually almost double in the group that received Gemcis-Nivo compared to Gemcis alone. And this is the OS. Again, almost double the OS, and you know, three to four times the PFS. So I think the question is, are there people who should be getting Gemcis-Nivo up front instead of what I'm going to talk about next, EV Pembro? And I think this suggests that maybe a patient who presents with retroperitoneal or pelvic lymph node-only disease, maybe this is not a bad option. Chemotherapy, you know, we don't want to write off chemotherapy. Chemotherapy has value in urothelial cancer. Immunotherapy clearly enhances it, and maybe more so for this lymph node population. Speaking of EV Pembro, this has become the other first-line standard of care for metastatic urothelial cancer. And this is a patient-reported outcome study. Just as a reminder to this group, this was patients who were upfront, previously untreated, locally advanced or metastatic urothelial cancer who received enfortumab vedotin, which is an ADC targeting Nectin-4. Until this drug came out, I'd never heard of Nectin-4. You know, I've been a GU oncologist for years and years. It's just interesting. Sometimes these targets will come out of nowhere. And in fact, as you all know, it's highly expressed in urothelial carcinomas versus platinum chemotherapy. And this is really the basis for its approval and how it became really the new first-line standard of care. This is the OS curve, highly significant in favor of EV Pembro versus standard chemo, GC. And PFS was also significantly better. It does have toxicities, and this is why they did a PRO study and presented at ASCO, particularly this neuropathy, quite a bit of neuropathy, pruritus, more alopecia, rashes. So you can see the side effect profile, although most of those are mild, they're mostly grade 1 and 2. So similarly, they went through a series of PROs. So I'm going to go through this quickly again because the way I view these is not that it's not important to the patients, but what you're generally looking for on graphs like this is, you know, how does the group that received one drug versus the other do in terms of their quality of life? So if you look at change in worst pain, down is better, and you can see EV Pembro is better here than chemo. Same thing here. This is change in worst pain. This is global health status. Up is better here. That's one thing that really, I don't know why they do that to us. You know, it's like up versus down. You have to pay attention to the axis here. So you can see here it's better if it's higher. And similarly, you can see that, again, it's better if it's higher, and it's a clinically meaningful improvement in this green zone. And so you can see it here in this forest plot. In general, if you look at all of these EORTC patient-related outcome domains, you can see that they're different for different domains, but generally speaking, patients getting EV Pembro seem to do better than patients getting standard GC chemotherapy. So that's what they present here. Another important therapeutic, so between the two choices, I think Nivo GC versus EV Pembro, I think you still have the choice of either. I don't really treat a lot of bladder cancer anymore, so it would be interesting to hear the other expert GU oncologists on the panel to give their thoughts. But I think at least what we have here is that there's some evidence here that even if EV Pembro is a first-line standard of care for most patients, that the patients with lymph node-only disease might be a good candidate to receive Nivo plus GC. the other question, and it's similar to the prostate cancer example, what happens when you run out of these choices? Because unfortunately, none of these treatments are curative. And there was an interesting abstract at ASCO on trastuzumab deruxtecan. Of course, TDXD, that's approved in other cancers, including breast cancer. These numbers are really all over the map, which also is it's just a constant thing for us to try to understand because there's so much variability in how you read HER2 positivity. We'd love to hear Dr. Davidson's thoughts about this because obviously breast cancer has been dealing with this for a long time. But here you can see that the immunohistochemistry prevalence for 3+ versus 2+ staining for HER2 is really kind of all over the map when I look at these. But there's clearly a subset of these cancers that express HER2. And this was the phase 2 study, and you can see there's multiple cohorts. You can see all of these, and they presented the small cohort where primary response rate was the primary endpoint was confirmed response rate, and these were all patients who had already received other standards of care and progressed. And what you see here is, depending on enrollment versus central review, there was a slight difference. You see the enrollment, the local labs were much more likely to read 3+ HER2 staining. When it was done in a more rigorous central lab, it was much less. A lot of them were read as more 2+ than 3+. But in any case, these patients also had other mutations that might be clinically significant. You know, there's an FGFR inhibitor that's available. Obviously, if they have BRCA mutations, they're all eligible for PARPs. And so the response rate is here on the left, and you can see, it's a little hard to see from this, but the forest plot shows that the biggest response rate is in 3+. And you can see in bicentral, so if it's a real 3+, which is this orange dots, you clearly have an excellent response rate. In addition, if you look at the number of regimens, it doesn't seem to have much of an impact. PD-L1 staining, none of these have a significant impact, but if you do have PD-L1 staining, you are more likely to respond. But it's hard to say with such a small number. So I think the conclusion here is that you should probably stain all these patients for HER2 when they ever progressed on IO and chemo. And because some of them may be a candidate for TDXD, in general, it's about maybe anywhere from 20 to 40%, depending on whether it's centrally reviewed. But the ones who are certainly 3+ should get it. Maybe some of the patients who are 2+ should also be considered for it if you're able to acquire for them. And as you know, the FDA actually approved this as a tumor-agnostic indication, so you should be able to get it covered. Okay. And I have one observation. There was really very little in renal cancer this year in ASCO, but this was in chromophobe. As you know, chromophobe is a rare subtype of renal cancer, about 5 to 10% of all. And if you look at these numbers, I mean, these are subsets of randomized trials, and you can see, like, you know, when you're in the single digits, it's really poorly understood, unfortunately, about what to do for these patients. But you can see the response rates are also all over the map. But the general idea is that monotherapy studies, but also doublets, which include 2 targeted treatments, either TKI plus an mTOR inhibitor or an IO plus a TKI, you know, kind of variable response rates. So this is, the Dana-Farber did a retrospective study looking at monotherapy versus doublets, and they suggested that patients who receive monotherapy do worse than patients who receive a TKI-containing doublet. You know, you have to be careful with studies like this, you know. There's a reason why we give doublets to some patients and monotherapy to others. Usually it's because they're better functionally and they're younger and they're more capable of tolerating 2 drugs rather than 1, especially a TKI plus an mTOR inhibitor. But I think it's worth exploring, and I think the basic question is if you do see one of these rare tumors in your clinic, you should try to give them a doublet that includes a TKI and probably an mTOR inhibitor. Okay, I think that's it. Thank you very much for your attention.
Thank you so much, Dr. O, for this outstanding update. I really appreciate it. Thank you for coming down here. My name is Dr. Mufti Ahmad. I'm one of the medical oncologists with TriHealth in Cincinnati. So I would like to open the floor for discussion or questions or comments.
William, great talk. Thanks so much. Can you comment upon your strategy for sequential versus intermittent hormone therapy and sequential anti-androgens or combining anti-androgens?
Yeah, so the question, I think, is in a patient who doesn't have visible metastatic disease, and by the way, that's changing, right? Because now we can see so much more with PET scanning. But in a patient who has what we call biochemical recurrence, your PSA is rising, but you can't see anything, let's say, on a PET scan, on a PET CT, intermittent is absolutely an option for those patients. You can definitely stop the treatment. It's very rare that I'll give those patients continuous lifelong ADT. They do not like it. But it creates anxiety, right? Their PSAs go up, and then you get a lot of calls, and then it goes down, and then it goes up. But I've done that through cycles for many of my patients. Now, what's interesting is with enzyme monotherapy, and I've used some of the other ARPs. I don't know if you guys have, but I've used other of the ARPs. The darolutamide, for example, is available, maybe a little bit better tolerated. What happens is, as you saw, when you take away the androgen-targeted therapy, because their testosterone is so high, their PSA goes up right away or very quickly. You have to be prepared for that if they are on an ARPI monotherapy. But I think for patients with no visible METs, intermittent is completely an option. I think if you have METs, I think that's a more interesting question, because those men also want to come off treatment. They don't feel great either. And what our strategy has generally been is to target oligometastatic disease. I didn't get to talk about this, but let's say the patient has 2 or 3 METs on a PET scan. We will radiate those with SBRT. And we're doing quite a lot of that aggressively, as again, because we know it's well tolerated, and we know there's some data that suggests that it delays progression. We don't know that it improves their survival, but it may actually delay the need to go back on hormonal therapy. So we're often doing a combination of both.
Yep. Thank you. That was a great talk.
Thank you.
So, as a urologist, let's say Pluvicto gets approved in the pre-chemo space, right? So it probably will. So when we get this patient with a high grade, metastatic disease, visceral Mets,
Yes.
are they going to go for Pluvicto, or should we go chemo, or what should be the algorithm for differentiating those folks?
Yeah, so of course I avoided saying the brand name because I know you're CME, so I was LU-177, PSMA therapy, poorly differentiated, Gleason 9, liver mets. This guy walks in, you put him on hormonal therapy, he should get chemo up front for what we call metastatic hormone-sensitive disease. But let's say a short time later he starts to progress, okay? And how do you know he progresses? Well, usually, even in those patients, you see the PSA start to rise. So it's a little bit of a mistake to think that PSA won't rise. PSA is still a really valuable test. But in that patient, if he's progressing, before giving him, let's say, LU-177 PSMA therapy, I will actually do an FDG PET often in those patients. If you can't get an FDG PET in addition to a PSMA PET, even just a diagnostic CT is very valuable. So when I order a PET CT, you can order just a regular PET CT, or you can order a PET CT with a diagnostic CT. And that's very good at picking up. Remember I showed you those discrepant cases? LU-177 won't work for those guys. They progress very quickly through it. And those low PSA producing, aggressive, visceral MET kind of patients, those are the ones who probably need more chemo.
Do you mind just introducing yourself? What was it?
I'm Mark Delworth. I'm a urologist with the local urology group here.
Thank you so much.
Thank you.
Yes.
If you could introduce yourself.
Yeah, Nancy Davidson from the Fred Hutch Cancer Center. William, not my field. Are you routinely doing germline BRCA testing for your new metastatic prostate cancer patients?
Yeah, it's really, really important, Nancy. And as you know, obviously, again, we're always following in the backs of what you've learned a long time ago in breast cancer. The most common germline mutation in advanced prostate cancer is, in fact, BRCA2. And depending on the population, it may be present in 5 to 10% of all metastatic prostate cancer patients. I didn't get to talk about it today, but you should be doing both germline and somatic testing in all of these patients. I recommend it at the time of metastatic disease. I think you can do it in high-risk localized. I think the urologist can do it right when the patient walks in if they have other high-risk features. The problem is NCCN guidelines are very confusing. If you try to actually see like they say if you have two cousins and brothers, and it's very, very confusing. So I think if you start by saying you're going to test every patient with metastatic disease on the germline right up front, I think that is very reasonable. And I don't know in Cincinnati if it's going to be 5% or 10%, but 5 to 10% will actually have a DDR mutation, most common being BRCA2. And they are candidates, obviously, for PARP inhibitors. And there's going to be more and more studies showing that you can give those PARP inhibitors early, like not waiting for them to have already progressed, for example, through chemo.
So I have maybe a couple of questions. So you've done and published quite a bit with the Prostate Cancer Foundation, and especially screening in Black men. In your data, you present quality of life is very important in this subset of patients, especially in prostate cancer. How do you decide which tools you use to best evaluate? Because every study seems to have a different tool. And also, just my personal thought, I also practice hematology. We see quite a bit iron deficiency affecting quality of life in a lot of these patients. So how do you integrate maybe some of this into those evaluations?
Yeah, so I think I'm going to take those two separately. Obviously, one of the things about prostate cancer that's both a good thing and a bad thing, I mean, it's mostly a good thing, is that the men live for a long time. The bad part of that is we affect that quality of life, right? And hormonal therapy is a very, very good example of it. It's one that for many decades, nobody really appreciated what we were doing to these men. They were falling, their muscles were getting weaker, they're getting cognitive issues. You know, I've had patients have osteoporotic fractures, so everyone knows you have to be monitoring them for things like that. So I think we do underestimate the effects on their quality of life. And these are often older men who live for years on this treatment. And so every single person in this room, doctors, but nurses, social workers, everyone understands that it really affects their long-term quality of life. So it is important to see these formal randomized trials with quality of life instruments, but all of us see it every day in our clinic. That is why Embark, that study that looks at, it's not perfect. If you notice, the quality of life was not better with enzalutamide monotherapy, although I think that's a bit of a fake out, honestly. I think that these drugs are definitely better, but it has to be, the reason it's not that much better is that there are some guys that we give ADT to, they're really not affected very negatively, right? We've all seen this. Mm-hmm. But then there are guys who they hate it. They hate it. It's ruined their lives. And so that's why when you do an upfront randomized trial, you may not see the same benefit, but if you actually select the patients who will do anything to avoid ADT again, right? Let's say they got it with radiation up front. Anything to avoid it, those are the people who I think do better. And just a question on the Black men. I know you have a sizable Black population here in Cincinnati, and I did spend a lot of time talking with Bill Barrett about this when I was at the Prostate Cancer Foundation. We published a guideline for Black men in the United States. Black men have 2 to 3 times the death rate of prostate cancer in the United States. They have 2 to 3 times the incidence. And there's a lot of discussion about why that is. But one thing we know is Black men are diagnosed earlier in life, in their 40s, versus the average white or Asian man who is more like in their 50s or 60s. So, and we also know that the U.S. Preventive Services Task Force has kind of, I think, confused the issue more by both changing the guidelines and also not really giving clarity to different high-risk populations. And Black men are one of those. And so I think that we published this paper in NEJM Evidence that was an evidence-based. It's not that AUA and NCCN and ASCO don't have guidelines, or USPSTF. They all do, but I call it a footnote problem. Nobody reads footnotes. And the highest risk patients are buried in the footnotes. And so when we published this paper, we said, let's go right after this population. Let's speak to them. And I think as CCA and UC kind of maybe thinks about how to target at-risk populations, the 2 high-risk populations for prostate cancer are Black men and men with a genetic or family risk. So if you take a comprehensive approach to this, I think there's a lot that could be done to reduce mortality and suffering from prostate cancer.
I don't know if you have any questions. I have one more.
Oh, go ahead.
No, go ahead.
No, go ahead.
Okay. So just, I know when the PSMA PET scan came out, there was talk about we may be underestimating metastatic disease even in what we think it could be localized disease. What is the best moment in prostate cancer diagnosis to management that you fit that in? What is your best advice on that?
Well, I know there's some urologists in the room, and we are oncologists, but I actually see a fairly robust practice of men who are trying to decide what to do for localized high-risk disease in particular. Mm-hmm. So if you have high-risk features, PSMA will not only be reimbursed, but it can be very valuable. So these patients have already had an MRI. Don't get a bone scan. Don't order any more bone scans. Just get the PSMA PET. And you remember, you get a quick and dirty CT with it. They don't need an IV contrast CT. They already had the MRI. And the PSMA PET will tell you if you can see the cancer in the prostate, which in and of itself is kind of interesting. Like, I am seeing a lot of localized prostate cancer where we can see it inside the prostate. And we see these SUVs. So the way I describe it to patients is the SUV is like the wattage of a light bulb. So if it's very bright, we know in the advanced stage that makes you a good candidate for drugs like LU-177. But in the localized state, it doesn't necessarily change what we do if they're a candidate, let's say, for surgery or radiation. But it might, in fact. I'm sure, Bill, you're using the PET scan to kind of decide what your fields might be and whether you do a pelvic field and so on. So the answer to your question is it depends, of course. I'm doing it in newly diagnosed patients with high-risk features. It's the first thing I do when their PSA is rising. Again, you have to be able to justify it, and we're usually able to get it if the PSA is over 0.20. 0.20 is usually the cutoff. I'm doing it at the time of metastatic disease, mostly to understand the nature of their cancer. Like, do I believe where it is? And then I'm doing it, of course, at the progression to CRPC, because at CRPC, I'm able to decide when I'm going to be able to give them LU-177. And I tend to do it, it's become my primary imaging because it captures almost everything for these patients.
Something I feel like I struggle with patients is sometimes when we get these discordant PSMA PETs where maybe we're upstaging them and there's not a good CT correlate, and then our data is sort of behind where we were using CT bone scan for a lot of our big trials, but now we're seeing this. Should we cover our eyes and not see it? Are we seeing it? And then, but then we're upstaging people. I guess, how do you think about that?
Yeah, it's a really good question because there's clearly false positives even with a very good test like this. Like, for example, the ribs are a pretty common area where we'll see some uptake that we're not sure it's real. And I've had patients where they had a single bone lesion and we didn't treat it, and now years later, it has never relapsed. So it wasn't probably prostate cancer. But the ribs are the most classic, and what I often do is I will often get an MRI. If I get two pieces of data that confirm that it's metastatic, then I will consider, if it's an oligometastatic patient, to radiate it. You know, the treatment of oligometastatic prostate cancer is controversial. I mean, it is not everyone subscribes to it. There are two small randomized trials that have looked at PFS as the endpoint in absent any ADT or hormonal therapy. And it clearly delays progression if you radiate, under 4 lesions. But does it keep them alive longer? Not necessarily. I think the question of like what is real and what is not is one that's still evolving, considering it's such a new test. But I was on a panel recently, a week or two ago, and I said, I haven't ordered a bone scan in years. And a very famous urologist kind of yelled at me. He said, how could you not order a bone scan? But bone scans are terrible tests. I mean, you guys have all ordered, they're terrible. I mean, for years, we've learned what to ignore on bone scans. And so I don't understand why he was so mad at me for not ordering a bone scan. I think for prostate cancer, it's not a perfect test, PSMA, but it is clearly, one where it is, I think, as we get more experience, we'll know what's false positive.
So we'll take the last question. Thank you.
Do you have trouble getting coverage for all those PSMA PETs?
It's always an interesting question. Like, I go around the country, and people, some places, they're like, we can never get that. And we do have a staff that appeals. We have a lot of appeals. It's a lot of work to appeal. I had a patient with febrile neutropenia, and he's coming in for docetaxel tomorrow, Monday, and it's like forever to get him, Neulasta. So the answer is sometimes, but most of the time, not. I think in the early disease setting, it's actually, the label is actually approved for early high-risk patients. Biochemical recurrence, I've had them rejected if the PSA is not 0.2, and then we just tell the patient and we wait. In CRPC and metastatic hormone-sensitive prostate cancer, it's not a problem. Have you had any problems getting it reimbursed?
Every so often, but then we just appeal, and I
Yes.
talk to a physician, and they understand, yeah. But sometimes with Medicaid too, I've had issues, but.
But I agree with your growth factors could sometimes be more difficult.
Kind of crazy.
Thank you so much. Really appreciate the wonderful discussion.
Thank you.
Thank you.